Welcome to our second episode of Clits and Coffee. Today's episode is going to be on Coccyx pain. My name is Melanie. I'm a physical therapist that works with pelvic health and orthopedic conditions.
And I'm Zoe. I'm also a pelvic floor PT and ortho PT.
Great. So first, I want to take a time out and say that we're really legit today.
Yeah.
We got a tripod, we got a microphone, we got a light.
We got coffee mugs.
We got coffee mugs, we got everything. This is going to be great. Okay, so today I was thinking I would talk about the way a clinical presentation of a patient that might come in to see us and have our focus really be on coccyx pain, what things we'd want to assess, and then different things that you and I might do that might be the same, or some things that you might do differently than me, and how we work through getting that patient feeling better.
Yeah.
Great. Right. Okay, so we'll say patient comes in, female, mid-30s, coming to see me for coccyx pain. And if we think about where the coccyx is, this would be a model of our pelvis. The coccyx is going to be the bottom of the tailbone or the bottom of the sacrum, and it's a little triangular shaped bone. There's no nerves that go through there. It's a fused segment, and it's going to kind of just tuck under through there. Lots of different muscles are going to attach to the coccyx, and then it's also going to be important for bowel movements as well. So it's going to be in one position. If we're not trying to have a bowel movement, it's going to be in another position if we are having a bowel movement. So the coccyx can be something that can be very important, obviously. If someone has pain in that area, they can also present with many different dysfunctions as well. So that's kind of what we'll go through with this patient. So mid-30s, comes to see me for coccyx pain. We start going through her history, and come to find out she reports a lot of other pelvic floor dysfunctions. So she reported a previous history of chronic constipation. She had a history of endometriosis that also resulted in a lot of pelvic pain, painful periods. She was having pain with sex with her partner, and she'd been having that for years and years and years and years. Never got treated for it. And then she was sitting more for work throughout the pandemic, so she was, not moving around as much during the day, and she started to get this severe pain described as sitting on a sharp knife. Okay, so she waited to get treatment for 1 year. So for 1 year, she's sitting on a knife, having to offload different positions, and also probably developing a lot of different compensatory movements that I think by the time that I saw her, potentially with someone that's been in pain that long, you can feel the pain and stress on them, that it's been going on for this long, and that also when people are experiencing this, they might not think that there's anything that can be done as well. So with that clinical presentation, what sort of things would you want to look at during your evaluation?
Well, one thing that came to mind is, has she seen another provider before about this?
Yeah. No.
Okay, so you're the first person she's talked to.
Outside of her primary care, yeah.
Okay, so seen primary care.
Yes.
I mean, the big things are knowing her history and all of the other pelvic floor things that have been going on. Has she ever done treatment for them? If so, what worked? And then also just kind of learn more about why it took her so long. Does she think she can get better?
Yes.
Because now we're kind of in that chronic pain state. That doesn't mean there's not something going on a physiologic level, but there's also that psychological component of 1 year of pain.
Absolutely.
So those are some big things in the back of my mind. And then learning more about bowel movements, all of that.
Well, I think also the psychological component, she had a long history of pelvic pain, but this coccyx pain, every time she had a bowel movement, it was terrifying because it was sharp pain. She, a lot of times, even trying to be intimate, the coccyx, that location, if there's a lot of immobility through that area, creates a lot more pain. So thinking about the psychological impact of having something like a bowel movement, being able to be intimate with your partner, those things are feeding into the stress inside the body that can also lead to even more guarding and more tension.
Yeah.
Yeah.
So where do you start? What did you decide to do?
Okay, so I started with the normal orthopedic assessment. So, checked range of motion in the back, nothing significant to report with back movement, lumbar movement, checked range of motion in the hips, so internal, external rotation, and actually had less pain with external rotation in sitting. So I measured it in sitting, and external rotation created relief for her. Thinking through that, I was like, did it potentially slack some of the muscles so it like maybe created less tension? Did it offload the coccyx somehow? Like that external rotation was a really, really big thing that stood out immediately. It was like, this is the first time I've been in a sitting position and I don't have the pain. If you had any other...
That's actually thoughts. Like, in my mind, the opposite of what I would have thought.
Right.
So yeah, it's interesting.
Interesting. So just something to think about. Okay, well, if that position provides her comfort, then let's start thinking about her plan going forward. Then maybe we can incorporate that to get some relief. And then, started going through the like sacroiliac cluster, and she had reproduction of symptoms with thigh thrust, so pushing the femur down towards the sacrum, and then sacral thrust was very uncomfortable for her. So pushing at the top just created the coccyx pain, pushing at the top of the sacrum. The other thing that I found interesting for her, I tried long axis traction, so just pulling on the leg to create a little distraction force. In my head, maybe thinking maybe this provides some relief. Did not.
Oh, okay.
Did not provide relief. It made the pain worse, which also got me thinking about like, sometimes especially with SI pain, distraction can often feel better, but coccyx pain, that movement creating more of that force down below was no good for her.
Okay.
So those were some of the, and then palpation. So day one is external exam, palpation at the hip rotators, glute med, a lot of tenderness through piriformis, which is something that I kind of figured would be, but she could barely, she couldn't tolerate a lot of pressure. So also that pain episode where she's just like almost like scared to be touched in that area because it could recreate her pain. Mm-hmm. Measured hip strength, external rotation, internal rotation, adduction, abduction. And there was definitely some, weakness through that area where I was like, well, we will need to address this when we get your pain a little bit more under control.
Yeah, but nothing that was like stood out as like, oh, this is a big deal, like kind of within the norm.
Right, exactly. Yeah, I mean, definitely needed to do some strengthening.
Right.
But it wasn't like right was this and left was that, and it was completely different.
And did any of those increase pain, like any strength tests?
Yeah, and I think that it's just like because she had been so guarded for so long, I think it was also that she hadn't done those movements. Manual muscle testing, we are having to move through motions. Yeah. So I think it was also the fact that she just hadn't moved, that she was almost just scared to move.
Right.
Yeah.
Okay. And I mean, a lot of those tests we're doing sitting, and then now we're offloading one side, so you have literally probably some more weight, because it's not like she's offloading and going over to one side. She's like sitting on her tailbone, lifting one leg up. Like that's just not going to be comfortable.
Exactly. Would there be anything else? So, this wasn't something that we did on the first day, but would there be anything else that you would want to look in the future for examination?
I mean, obviously, like, I think if they're open to it, when it comes to coccyx pain, an internal exam. Yeah. And depending on the person, I mean, when it comes to the coccyx, like, I'm thinking more of a rectal exam if they are comfortable with it.
Yeah, I 100% agree. Would that be something, would you want to wait until you got their pain a little more under control, or would that be something you would do within the first, 1 or 2 sessions?
I think it depends on how guarded they are. Yeah. And so for her, it sounds like she's pretty guarded.
Yeah.
And you have hip external rotation as something that could be a little bit relieving. So can we do that? And then think about doing the internal exam later, or do we use it as a thing of like, okay, I think it would be helpful to do the internal exam and see if we can alleviate some discomfort And if it increases it, we have this thing to go back to that works to reduce your pain. So starting with the internal exam and then doing hip external rotation exercises after, if we've already found, so I guess it would probably be third session if we found that that helps alleviate pain.
Right. Or the concept of this might hurt, but we also have a way where we can do treatment immediately too, which is the other, great thing. During a rectal exam, we can go immediately into treatment, and although initially it might be where she's guarded and she's in more pain, we can do treatment right then and there. We could get her out of the pain. We could help her literally right with that exam and just go straight into treatment.
Yeah. On the flip side with her, like, she does have the history of endometriosis and pain with penetration. So does she have pain with OB exams?
Yeah, pain, she didn't, and she never used tampons, pain with medical exams, pain with penetration. So yeah, she did fit that clinical picture where all of that is going on.
So that's something to keep in mind with the internal exam. It might be too painful, but it is, for a lot of people, it can be helpful in actually mobilizing the coccyx a little bit.
Yeah.
Where you're like, I don't want to increase tension and guarding, but this is a treatment strategy that might help. So maybe like an external kind of like the drawer technique, which we can talk about to start, and if that helps, then I'm thinking internal will probably help.
Right. Okay. Oh, I like that actually. Doing that technique first, and then knowing that, okay, creating some movement actually does help. I do want to back up for a second because I wanted to also just discuss some potential causes of coccyx pain too. One of them, in this situation, we've already heard that one, prolonged sitting, with some other chronic pelvic pain conditions contributed to this particular clinical presentation of coccyx pain. But what would be some other ones that come to mind for you?
I mean, those are some big ones where it's like a history of constipation, potentially endometriosis or fibroids, maybe a pelvic surgery, things that go towards that pelvic floor tension side of things, and then prolonged tension, like over many years. Now the tailbone's getting pulled forward, and so the why behind it, like the sitting is painful because all of these other things have happened for so long. But other times I see it as a lot postpartum.
Right, yeah.
Like
definitely.
After labor and delivery and pushing, there can be some coccyx injuries.
Yes.
Or like a fall on the tailbone, so like falling while skiing, falling down the stairs. If you're, like I was a gymnast, right? Like a lot of us fell on our butt a lot.
Yeah.
So things like that, ice skating falls, like,
yes,
those are the big ones.
Yeah, I would. Yep. I would agree with all of that. Yeah, and even I've seen horseback riding.
Oh yeah.
Rowing was actually a big one because you're constantly almost like you're not like on your coccyx per se, but you are constantly putting pressure. Where if there is some other things going on, other muscle imbalances going on, that could create that as well. So yeah, really interesting. A lot of different things can contribute to it, but I also don't think that it's something that is overly common, like localized to the coccyx. Like I feel like I see more tailbone pain, SI pain, than I do specific coccyx pain.
Yeah, I agree.
Yeah.
And so for her, what do you think like drove the symptoms to this point? Like why did she now, or like a year ago, start having this pain? Because it wasn't a fall, right? So if we're thinking about treatment, sure, we have some like potential options of treating the pain, but why did it happen in the first place, and how are you going to address that?
Yeah. I think the bigger question also is why after so long did you finally decide to ask for some help and stuff? But I think that for mentioning it to a provider, I think she was probably trying to get help for some of the other things, and then also I think she was trying to get help for some of the other conditions that she was having, and then she mentions this coccyx pain to her provider, and her provider's like, why have you been living like this? Like, physical therapy can be 90% of cases can respond really well to physical therapy, conservative management. But yeah, so where would I start? So I think day one, especially with someone who is so pain driven and really fearful of movement, I'm going to start slow. I'm going to start very, very slow. So one of the things that I think works really well is taping to the coccyx. So day one, it's something I can do right at the end of the treatment, where you apply leukotape. So leukotape is a non-flexible tape, not like kinesio tape that is flexible. And basically you anchor at the coccyx, kind of butt crack area, anchor it down and then pull up and then anchor that top piece. And that just creates just a little bit of almost like extension. It gets it out of that flexed, sitting on a knife feeling, and just creates that little bit of traction or distraction of that area. Also can help relax all of the pelvic floor muscles that are in that area as well. So that was one thing that I felt like I could start day one, and that wasn't going to be overly aggressive either, and then also provide some relief. The other, I didn't mention this during her exam, but also pain with pelvic floor contraction. So, I had her side lying, palpated at the coccyx, contract the pelvic floor, much pain went up. Okay, also had a lot of difficulty relaxing, so which I kind of anticipated. Relaxing the pelvic floor was very difficult for her. So one of the other things I gave her was a reverse Kegel, where she contracts and then slowly relaxes, almost like a slow lengthening of the muscle. That actually really did help her learn to relax. So do the contraction, but that's not the exercise. The exercise is letting go of that contraction. And then just some static piriformis stretching. So just started with that. So she had piriformis stretching, reverse Kegels, and then the taping. Let's see how you respond to that.
Is it did you teach her how to potentially tape on her own if it provided relief, since it can only stay in place for a couple days?
Right. No, that would be something like the next session.
Okay.
So the next session, was that helpful? And yes, if it was helpful, can we provide a way for you to do it at home? Can your partner assist you in this taping technique, provide you with some relief?
Gotcha.
And okay, so we'll follow up to the second session, doing 80% better.
Wow.
Right. Exactly.
Okay.
We haven't even started.
Like barely done anything.
Right. We haven't really even started anything. We did some bowel positioning techniques and stuff, squatty potty, so elevating your feet. When you're having a bowel movement, we went over some breath sounds for that. So also just like some general things that she could do as well, to help with having a bowel movement. But yeah, had a really good response to stretching, learning to relax the pelvic floor, and then having just some of that offload of the coccyx.
Yeah.
But there's still work to do. We're at 80%. We still have 20% to go. So then, yeah, I feel like now let's get into potentially some of the internal stuff that we could do. Yeah. Some of the techniques with that.
Did you do any internal work with her?
No. Mm-mm. But this is, we haven't had that many sessions yet either.
Do you feel like at this point, though, if she's 80% better with pretty much all external work and education, and there's still a lot of external stuff that you could do you feel like an internal exam would give you more information or would be helpful?
That's actually a good question. I think I would agree almost where I feel like where you're kind of leading to right now is there are other things that we can address, and particularly if she is someone who maybe is uncomfortable with an internal exam or knows that could be something painful for her, right? Are there other things that could we start working on the strengthening side of things? Teaching her some of the self techniques for even soft tissue mobilization through the piriformis and stuff like that. Like, I do think there's a lot of external stuff that we could do to get that last 20%.
Yeah, because like my mindset, I guess, at this point is she does have a lot of other stuff going on.
Right.
And so I do feel like if she's open to it at some point, a pelvic floor exam might be helpful, and honestly, like maybe a vaginal exam and not a rectal exam.
Yeah.
Because you're still getting information, but then we're also thinking about like she does have endometriosis, painful periods, pain with penetration. So we want to make sure that at some point we address that, and that's probably going to be more vaginally than rectally. But can we get to a point where she's comfortable, tissues have calmed down a little bit, and give her tools and have like a toolbox of things she can do that help reduce her pain, so that if that experience, again, like if it's painful, we already know enough and she's comfortable to say like, okay, then I do X, Y, and Z, and that will bring me back down.
Yeah. No, that's a really good point. Her coccyx pain is 80% better, but yeah, we have years and years and years of a pelvic dysfunction, pelvic floor dysfunction that needs to be addressed as well.
Yeah.
That like this coccyx pain is only a small piece of the puzzle that she has been dealing with for so long.
Yeah. So I guess like I think in the second session I'm probably doing an external mob.
Okay.
Gentle, because the taping helped. So we're moving in that direction, kind of like the muscle energy technique. There's something with like that little bit of feedback that works well with her. And then probably more like pelvic floor relaxation techniques.
Yeah.
So probably some diaphragmatic breathing and checking in on pain, and probably doing it in a position where her hips are in external rotation.
Yeah. Yeah, absolutely. I mean, that position of comfort. Can you walk me through the MET, the energy technique?
Yeah, I mean, this one is just like patient is sitting, right? And we're at the coccyx, and they'll contract their pelvic floor, and it'll be a gentle contraction, and then we're doing the like eccentric or elongating, relaxing, and as they do that, almost pulling back on the coccyx. So they're relaxing and we're mobilizing externally.
Okay.
And it's paired with the pelvic floor contraction to start. So contract, relax, and we mobilize, contract, relax, and mobilize, and then reassess. So where was your pain to start in sitting? Where is it now? Did it get better, worse, stay the same?
Yeah, love that. Also, like the tactile feedback for even the pelvic floor relaxation as well. You know, you can get like so many things with that. Like, is it actually that we're creating movement, or is it also that we're providing feedback for how the coccyx should be like moving and responding to a pelvic floor contraction and pelvic floor relaxation?
Yeah, and that's going to carry over into bowel movements, which she was having trouble with anyways as well. So like there's a lot of benefits to just like the proprioceptive feedback of like, where are my muscles, where is my body in space?
Yeah, absolutely. Love that.
And then I think like incorporating, like I said, some diaphragmatic breathing. If she's comfortable like in butterfly position and hip external rotation, then doing that there, and knowing that one, we're reducing discomfort, two, we're working on elongating muscles, but she's been in a state of chronic pain for a year.
Yeah.
So there's always going to be a nervous system like sensitivity aspect, and diaphragmatic breathing is going to help bias a little bit more towards the rest, digest, nervous system, bring down that stress, that pain response. And so not only are we impacting the muscles, but we're impacting the sensitivity in the muscles from the nervous system.
Yes. No, I think that that's really powerful. I mean, even just, you know, like I said at the beginning, like when you can feel pain on somebody, like that is what they need, that bring down the nervous system, decrease that sensitivity, decrease that hypersensitivity, and let them be able to release pain, like not be so like controlled by it.
Yeah.
Yeah, I think that is very powerful.
So yeah. And where would you go? Where are you guys at? What's the plan?
So yeah, we've started, you know, after things were moving in the right direction, started to do more of that like down training side of things. So butterfly position, happy baby position, cat camel was really, really powerful to be able to, you know, let the tailbone, let the sacrum, let the coccyx move back and forth, and it also not be painful. And then, you know, going forward, yeah, I think that kind of, you know, what you were saying is, do we do a further assessment, internal assessment to actually address some of the pelvic pain conditions that she's also dealing with, and then go into other techniques for reducing the pelvic pain.
Yeah. And I mean, she came in for this tailbone pain. Like, is it a goal of hers, or was it on her mind to address any of the other pelvic floor things, or was she really there just for tailbone pain?
Yeah. So she no pregnancies yet, but she is hoping to become pregnant, and she has been very limited with being able to be intimate with her partner due to the coccyx pain for a year, so a very, very long time. So I think that I think after knowing that pelvic floor physical therapy is a thing, and there are techniques and there are strategies and there is treatment to help get not only this problem better, but also taking a look at all those other things. Yeah, I mean, I think that it is definitely a goal of hers to address the other stuff going on for sure.
Yeah. And I don't know about you, but I feel like this approach, or like why people come in, is pretty common, where like they'll come in for one thing when really they just didn't know that like all of these other things can be addressed. And maybe it's not the goal at the beginning, but when you talk about like, okay, I'm going to ask all these questions, like I'm going to ask about sex, I'm going to ask about constipation, because they're so important to tailbone pain, and like thinking about why is this happening, like what led to this,
right?
And then it becomes apparent, like, oh, well, that's a goal too, but I didn't know that that could be a goal,
right? Yes.
And I like, of course we're talking about this presentation, but I think this is one of the more common presentations that I see with tailbone pain, where it's almost like secondary to other things that they didn't know could be addressed.
Right, exactly, yes. Yeah, I mean, and then, I mean, having the conversation in general, like, I mean, I think that that's one of the great things that we're able to provide our patients, is having the time to let them tell their history. Like, someone actually asking the questions that they might not be comfortable talking about, or nobody's asked them those things, and actually really diving deep and letting them tell their story and be able to like open up and say like, oh, well, I had no idea that this could even be helped or addressed, or that there were providers who could address this.
Yeah. Or that mattered for their pain.
Yeah.
Like my history, my first session with people, because there's so many things that matter and we have to ask these questions, like it takes me I would say on the shorter end 25 minutes.
Same.
Because
yes.
That it's so important to figure out all of the information and then try and see like what are the trends, like what do I commonly see in patients who present like this, and know where to go. Like of course at the beginning we're trying to reduce pain, but now we're trying to keep it that way.
Yeah.
And so making sure that we're treating the problem and not the symptom.
Right. Yes, exactly. But 100% agree. Like history, I feel like when I started PT, it was kind of like, let's get through the history so you can get to your objective measures. But like the history is where you're gonna find all of the information. So I do agree, especially with these with pelvic health conditions. It's really important to not just look at this episode, look at the long-standing history and not be like hyper focused on the episode that they're coming in for. Again, because you can usually pick those things out. Okay, coccyx pain, all right. Do you have constipation? Yes. Do you also have pelvic pain? Do you have pain with intercourse, pain with medical exams? Yes. Do you
tampon use?
Urgency? Are you right? So like they start to create. Do you have urinary symptoms? They start to fall into that pattern that's so common that unless we ask those questions, we won't really get the answer.
Yeah, because I mean, no one else, not no one, but most people aren't asking those questions, and I get a lot of like, I try and explain it in advance, like, is it okay if I ask these things, because they all matter, and otherwise, like, people won't necessarily bring it up because it doesn't feel like it's relevant.
Right. And
so it's just been an interesting experience of like going down that road and having people realize just like how interconnected it all is, and kind of even then they see for themselves almost the progression of, okay, that's why.
Right.
And then there's a little bit more hope of like, well, okay, then that means we can do something about it, because they can see the timeline of how it happened and kind of why.
Yeah.
Yeah.
Anything else that you want to talk about for Coccyx pain?
I feel like that was pretty good.
Yeah, well, and I do think that just because we kind of sort of touched on it, but we really didn't dive into it, mainly because I think we both agree that the rectal internal exam isn't the thing that we need to do right away, considering that she got better with other things. But I do think it'd be worthwhile maybe doing an episode on what a rectal exam and what rectal treatment might look like in the future, so that we could kind of dive into that a little bit more.
Yeah, I feel like a lot of people already don't know what a pelvic floor exam looks like, which we're going to get into.
Yes.
So, I mean, it's still a pelvic floor exam. It's just normally they're like, okay, pelvic floor, vagina, and that is only one option for doing a pelvic floor exam. So, yeah.
So true. Yes.
I think we can dive into what all of the options are and what that would look like, what treatment would look like, and why one versus the other.
Yeah. All right. Well, we hope you enjoyed this episode of Clits and Coffee.
And we'll see you
next month.
Next month.
Yeah. See you next month.